Hello everyone, welcome to another exciting episode of MedSynapse podcast series. I'm your host Hedvisha, and today we'll be discussing a critical aspect of diabetes care, which is insulin management. With diabetes becoming increasingly prevalent worldwide, understanding how to effectively manage insulin is more important than ever for improving patient outcomes. And to guide us through this topic, we have with us an extraordinary expert, Dr. Ayush Chandra. Dr. Ayush is the founder director of Nivaran Health in Ghaziabad and a highly accomplished consultant diabetologist and diabetic foot specialist with over 15 years of experience in this field. He's also associated with Yashodha Super Specialty Hospital and Nishkam Diabetes Care and Research Center in Ghaziabad. So, welcome, Doctor, and it is a pleasure to have you with us. And Doctor has prepared a detailed presentation for us on this topic, which is insulin management. Let's dive right into it and explore the nuances of this vital topic.
Hello everyone, my name is Dr. Ayush Chandra. Uh, I'm from Ghaziabad, work at Nivaran Health as a consultant diabetologist and a diabetic food specialist. And today I've been asked to take a topic at a lecture on mastering insulin titration in diabetes. So insulin is a very important topic if we are managing the diabetes. So most of us must be knowing what diabetes is. Diabetes is a chronic metabolic disorder. It is not a disease, it is a chronic metabolic disorder which is characterized by high sugar levels or hyperglycemia. Okay, so this could be due to lack of insulin in the body or no insulin in the body. So, no insulin typically in the cases like type 1 diabetes, and the insulin resistant cases, overweight cases, sedentary lifestyle cases, which develops into type 2 diabetes. So, this results in many symptoms like frequent urination, thirst, hunger pranks, weight loss, and other symptoms. And if it is not managed correctly, that can easily lead into complication involving eyes, heart, kidney, or your feet. So let's first understand how this mechanism works. So whenever the mechanism for the this thing diabetes will understand. So whenever a person eats something, it is being converted into food, and that breakdown ultimately gives us energy. That the glucose enters needs to be entered in various parts of the body through cells. Okay, but what happens in diabetes? There is an insulin resistance. These cells resist the glucose level, and ultimately they are not able to enter into various parts like brain, your muscles, etc., and they remain in the bloodstream, giving rise to the sugar levels, and ultimately these symptoms occur. So, insulin is the key. It is the key which you can see. It is the key to the metabolism, which allows the glucose to enter into various parts of the body. So, natural history of type 2 diabetes is very clear. As the diabetes progresses and this resistance develops in the cell part, so insulin resistance keeps on increasing, and it can also can give various symptoms and even the weight gain. So natural history of diabetes is pretty clear here. What we can say is this: as the diabetes goes like the progresses in the time, it gives rise to the insulin resistance. The fasting level goes up, and along with that, post meal levels, like 2 hours after the eating the food, it also goes up. And simultaneously, as this progresses, it gives a decline in the beta cell function. The beta cells of the pancreas, they start degrading, and ultimately this can lead to further damage to the pancreas. So let's understand how one can start the insulin, and also in which typical cases insulin needs to be given, can be given. So let's start with how the initiating of the insulin therapy can be done. So it can be, of course, it is mandatory in all the type 1 cases. Type 1 cases are very important in terms of insulin. And also LADA cases. So LADA cases, which is type 1.5 diabetes, it is very effective in that condition because oral drugs don't work properly here. Other cases I will be discussing here, like one is pregnancy. So prior to pregnancy, if metformin is not working, Then idle therapy is the insulin therapy in these cases. Then acute hospitalization, where the role of insulin is much more as compared to the oral drug, that is very important. Any hospitalization, acute illnesses, also post care, post operative or the intensive care, where you will always see whenever a patient is admitted, the role of insulin is very important here. So MI, high doses of glucocorticoid therapy, all these things, the role of insulin is very effective and important. Then newly diagnosed type 2 cases where oral medications, the combination fails. It normally the physician recommends now the starting of insulin would be much advisable. Now, taking the cases of DKA, diabetic ketoacidosis, often seen in the cases of type 1 diabetes. So what happens is this sugar levels go so up and the pH level is like totally disturbed. In that cases, the electrolytes, the insulin therapy is of a much important role. Okay, and of course, in those cases, the oral drugs and the lifestyle medications are failing the triple therapy, four drug therapy. Then we normally recommend, okay, let's start with the insulin therapy and go one by one. Taking few examples that would be much beneficial. Like a patient has now been diagnosed, or it's a known case of diabetes since many years, and the physician has started with metformin, maybe 1,000 twice a day. So if 2,000 mg is not working in a day, then the physician normally adds the second dose. So second dose can be a sulfonylurea. And like after 3 months, HbA1c is not coming down, the PP fasting is not coming down. In that case, what happens is we move to the highest dose of the second drug also. And if also with that the sugar levels is not coming down, the third drug is also being added. It could be DPP-4 inhibitor, pioglitazone, and all these things. And ultimately, if the result is not coming down with that drug also, the triple drug therapy is also failing, then there is a high chances that your physician, your doctor will start the insulin therapy. So insulin therapy would be recommended then. And now we will be discussing like what kind of insulin or what type of insulin we should be starting. And second is it where should be the timings of the insulin, what time the insulin should be taken. And very important is the titration. On what titration scale the insulin should be always increased or decreased in patients. So let's discuss the advantages of the insulin therapy. Okay. So insulin is, of course, the oldest of the measures in terms of medication and the most clinical experience, most effective in decreasing the sugar levels, and also it improves the HbA1c. But it should be given in the apt amount of doses, which is very important, and correct dosage should be always titrated by a doctor. Okay, and also it gives a greater impact on the lipid profile, triglyceride level, and the cholesterol levels. Now, if we look at the various data are available in the online or research paper, and there are a number of advantages if a patient has been given insulin and what impacts on what percentages the improvement comes. So whenever the insulin is being given, there is a normal 1% decrease in the HbA1c that is shown. The endpoint diabetes, there is an improvement 21%. Death can be avoided, and of course, MI, heart condition, stroke, PVD, all these conditions are very much improved. And of course, if a patient is on insulin, you can say efficacy is very better in terms of PP and fasting. And anybody who's opting for this is very practical example. Anybody who's opting for any kind of surgeries like tooth extraction, foot surgeries, or any kind of eye surgeries, cataract extraction, that cases insulin is being provided for certain like shorter duration, and a result is being achieved by insulin itself rather than the oral medication. So patients have a number of concern. You can say first is fear of injections, like if how will I like inject the insulin? What will be the sides of insulin? Where there'll be a permanent, I won't be able to get off insulin. So all these fears should be always counseled by doctors, physicians, and the diabetic educators. So the role of a health coach or diabetes educator is very important to educate the patient. What is the correct use and what is the importance of insulin and how the insulin should be used, titrated, and always, whenever there is a doubt, come back to the doctor asking their short or like major doubts. So, as I was saying, there are a number of worries which a patient can have, like what is hypoglycemia, when the sugar comes down, what I need to do, how I need to titrate the sugar, and what are the different regimes, the brands which are coming in the market. So all these concerns, always the patient comes. So doctor should, whenever he or she is initiating the insulin, he should always tell patients type of insulin, what could be the possible side effects, what combination should be taken. All these details should always be counseled before the starting of the insulin therapy. So if the OHAs are not working enough, then we move to the insulin and start the therapies. And what are the following signs? Look out for the signs. How much is the fasting and post meal levels are going on in the current ranges? How much is HbA1c elevated? Even if the triple or the double oral therapies haven't worked properly. So with that, uh, how much the HbA1c has gone up, this can help a physician to decide the type of insulin or whether to start insulin or not. Unexplained weight loss is also very important. Look out for ketonuria and the energy levels. Okay. So this I've already discussed. Just a second. So of course, it is very important to look at our pockets. So like sometimes what happens, physicians write the insulin, which is very effective, very high efficacy, but they are a very high price. So always just physician, if they keep a thing in this mind, ke, look at the patient pocket. Will they able to purchase it? Because it is not a one-time thing. They might have to take it 1 month, 3 months, 6 months. Just calculate the cost. Just look out the combinations which are there. Just look out the brands which are available in the nearby pharmacies, and accordingly, according to the patient pocket, you can decide which combination would be suitable for them. And available also. Availability is a big issue if we talk about the metro cities or the rural areas. So which combination like Mixstar 3070 very easily available. Then Glargine is very easily available as compared to the premixes, the analogs, some things you can say Rhizodec, which are still not available in the rural areas. So just look at it. So we would be looking at the types of insulin. First is your basal insulin, that is long-acting insulin, which is normally given at night time, sometimes at daytime also. It gives a longer impact. It has a very longer impact, and also the impact is very slow. Lantus, Glargine, NPH, these are the common examples. Then bolus therapy is a very short-term therapy, which we will be discussing in detail as part your Novo Rapid regular insulin. And premixes are a combination of two. It comes as a combination 30-70, 75-25, 50-50. So these are also available and very effective these days. So if we look at in details the bolus therapy, the meal time with meal or the postprandial ones, the first one which is very common is the regular insulin. So this is actually an intermittent kind of insulin which has a short acting. The onset is 30 to 60 minutes and the peak is achieved 2 to 4 hours. It is very important. And still it is called intermittent because the action of the duration stays around 8 to 10 hours. And the analogs which are available, the rapid acting, these are Lispro, Aspart, and these work very quickly. So 5 to 15 minutes they start. That's why we always ask, start them before the meals, 15 to 20, 30 minutes before the meal, so that the onset is being delayed. And the duration is 4 to 5 hours. Then inhaled insulin, which will be coming, Cipla brand would be coming, and they would be easily available in India in coming days also. This would be also very rapid acting, quick action, and also will stay for around like 2 to 6 hours. Basal insulin, that is the long acting, plays a very important role. So it is very important for a physician to go through the logs, the electronic logs or the manual logs, where the fasting is coming, where the PP is going over the time, like last 10, 15 days, and decide what kind of insulin is required. If fasting is going up and up and PP is stable, in that cases, the long-acting insulin will be very beneficial. And in some cases, the fasting is controlled, PP is going high. In that case, short-acting on the bolus therapies will be recommended. But in those cases, both of them are simultaneously going high. So the best therapy is the basal bolus therapy. So basal bolus therapy is very effective. The combination of rapid and the long acting. And the premixes, the analogs is a newer technique, very beneficial that can be also used. So NPH, as I was discussing, intermittent kind of insulin, this is not being used much in today's date, but still very effective. Was used in pregnancy period more, and the onset is 1 to 2 hours, and peak goes to 5 to 6 hours, and duration still is goes to around 12 hours. Glargine, your this thing Lantus, very commonly used. 90% it is being used long acting ones. It starts in 1 to 2 hours, and the effect is very flat, goes throughout the day, and remains long as 1 hour, 1 day. Okay, so it is very commonly used. The second is Detamir, also very commonly used, and the impact is this only. Regular we have discussed. Then the rapid insulins, the aspart you can say, and all these things. They also comes as a premixed insulin in a combination with other drugs also. So one is a Novomix, 30% of rapid aspart and 70% are intermittent. So this is also very good, very effective, which I also uses. Then the combination of intermittent acting aspart, that is 25% and 50% Lispro. This is also available as Humalog 25 and Humalog Mix 50. Very commonly used these days. So we were as I was discussing the combination of basal bolus. How it works is this: the basal therapy, the basal insulin has a flat curves, and it works almost like 24 hours. So that's why it is giving nighttime and it goes full days. And the rapid acting one, it has a very shorter onset and decreases the sugar level. So accordingly, whenever a physician should see the graphs of the maybe CGM graph or the manual graph and decide how much the PP is going on. Deciding on that, he or she should decide how much the insulin should be titrated. Premix, as I told you, it's a mixture of long acting and short acting, and whenever a single dose is being given, so we can decide the dose and we can use it one time meal time, like before breakfast, before lunch, or before dinner, and both the insulin work together. So this is a very good impact, but the only disadvantage is this: it causes hypoglycemia especially at the midnight, 3 p.m., 2 p.m. So look out for the hypoglycemia, and whenever there is a problem, go out for the consultations and discuss with your doctor. So there are number of things which are saying, a number of studies which are saying analogs are very improved and they mimic the actions of insulin secretion. So it is a combination, and always go and ask, clear all your doubts with the physician, which insulin would be good, what should be the timings, and whenever the follow-up should be there, go with the logs. Discuss this insulin was given maybe with some oral combinations, and this is the result coming PP and fasting, and what should be the further course of action. So maybe according to the dietary changes, lifestyle changes, the sugar will be coming down and insulin doses will be titrating in that case. Of course, these analogs are very effective, and the newer techniques which are coming, which has already come, is the insulin pen. So, number of pens, like ideally, it used to be insulin syringes, which we used to use in the hospitals and all. Now, the pen forms are there, and it is already like these pen forms. Every brand has its own pen, and it comes with a cartridge. So, these cartridges are available in the market and can be used multiple times, can be stored very nicely. Here, the role of a physician or a diabetic educator will come into action. Okay, how the insulin should be stored, how it should be refilled, what is the expiry, how it should be used, and the technique is very important. The correct technique will give a greater impact, and it has a multiple use, you can say, in the insulin pumps with the use of CGM. All these things work very nicely with them. So role of a diabetic educator is very important. Now, initiating and the adjusting of insulin, that is a another important thing. Okay, whenever it has been decided that oral drugs are not being in use now, or it will be given with the insulin, now the doctor will select okay, what kind of insulin would be added. Now, normally I say if the levels are high, you can say the fasting levels are going high and it is not controlled by the oral medication. Now, one can start with the long-acting insulin at night. So just look at if the oral medication, the sugar is still going 160 or 200, for example, like that, then one can start with 6 units. This is the ideal thing, bedtime intermittent insulin. Or here it is written, start with 10 units also. Or calculate the body weight, calculate the BMI, calculate the body weight, and one can go into zero point 0.2 units per kgs. So depending on that, just look at the monitoring levels, look at the HbA1c level, and if it is coming in range, one can continue the same thing. And it is not coming in control range, one can increase the doses according to the sugar levels. If the sugar levels are coming like 100, maybe 80 or 120 above, then one can increase the dose like 2 to 4 units in a day. Now, one can start with the intermediate or the long acting, or if the PP levels are also going high, then move slowly to the rapid acting also, and one can go to the basal bolus therapy. So one needs to deeply understand, one needs to chart how much the PP and fasting levels are going, and again check with the for example with 4 units of aspart, how much the PP levels are coming down. If it is coming down, then one has to reduce the insulin level. But if it is going up, still 40-60 unit is coming out, then one needs to increase the unit. And the target range should be 70 to 30, that 130. And typical doses is increased like 2 units every 2 to 3 days. Then again, if the hypoglycemia is coming, that is very dangerous condition because it can lead to many symptoms also. In that condition, if the sugar is coming down below 80 or 70, that time for talking the terms of your this thing long acting insulin, one has to decrease the doses to 2 to 4 units so that the sugar is being normalized. So just going to the second step, one needs to monitor the sugar levels. Let's see like 15 days, 30 days, how much the sugar is coming down. One needs to check the HbA1c level. So in that condition, if the sugar is level is fine, one can continue the level. But if it is the fasting is going above up and up, in that condition, maybe 4 to 6 units are increased, and no, one needs to go practical front and see how much the sugar is improving. And of course, the role of oral medication, diet, and lifestyle is very important to understand. So, intensifying the insulin levels in that condition, one needs to just target, to see the how much the HbA1c is, how much the PP and fasting is coming with these drugs, with these insulin, and just decide pre-lunch how much the insulin needs to titrate, pre-dinner also, and night time also. So these adjustments should always be done like 3 to 4 days, how much the improvement is coming. And always, if it is getting stuck or sugar is not improving, one can move to like basal bolus to pre-mix insulin. One can change the brands also, and always look for HbA1c in the 3 months. So premixes, as I was saying, it doesn't need much of the dose adjustment, but it has already the combination, and always it's required to be taken before the meals. That is very important. Step three is again like it is a similar thing. One needs to check 3 months how much the HbA1c PP levels are there according to just monitor the sugar level, keep changing the doses and the insulin time. And whenever there is a requirement, if 2 doses are not working, add a third dose maybe for the premixes I'm talking, as I had discussed earlier also. So choice of regime is always a matter of discussion, and doctor has to take a correct decision. There is no particular guidelines you can say of this, and you can say this thing. And if the oral medications are not responding, in that case, insulin is very important. Always look after the guidelines of ADA and the European Association of Diabetes, what the new guidelines are coming up. The IDF also gives recommendation for pre-mixes and basal every year. So physicians should always go through these new advances, the combinations, and what the new researchers are saying. And pre-mixes should be, of course, a choice, which I also say. So I think that's it for the today's session. I hope you liked today's session. If you have any questions, please drop in your questions, and I will be answering them soon.
Thank you, Doctor, for sharing your expertise and guiding us through such a comprehensive discussion on management. Your insights, backed by both clinical experience and holistic wellness approaches, are truly invaluable. So, thank you so much for joining us today. And to our listeners, thank you for tuning into this episode of MedSynapse podcast series. And remember, if you're a healthcare professional who is eager to delve deeper into medical topics or have questions, do not hesitate to join us on the MedSynapse platform. MedSynapse platform is not just a resource, it's a dynamic space where you can connect with your medical peers, participate in meaningful discussions, and contribute to the ongoing evolution of healthcare. So, until next time, take care and keep striving for better healthcare outcomes.